don't know me, right? So, all right, no long introduction needed. We have 30 minutes to do this. Makes it difficult, but nonetheless, I'm going to try to respect the time out, okay? Can you hear me?
Yeah.
All right. Okay. And so with that, I'm going to talk to you about addictions in the context of substance use and behavioral in terms of gambling disorder and what we call comorbidities, all right, or co-occurring disorders, okay? So these are the objectives, so bear with me. Please don't fall asleep, especially after lunch. I'm just going to throw out some quotes to you that I thought were pretty interesting. Key definitions you have to understand, and then we're going to talk about gambling disorder, substance use disorders. I'm going to share with you the common comorbid disorders, not only from my experience from working at the Science Rehabilitation Center for 10 years, but also based on the research that's out there. The management is important as well as the referral processes. So, this is a French proverb. Gambling is the son of avarice and the father of despair. In gambling, the many must lose in order that the few may win. Wow. By George Bernard Shaw, who was an Irish playwright, I believe. Michael Jordan, famous basketball player, said, I want people to know that gambling is not a bad thing if you do it within the framework of what it is meant to be, which is fun and entertaining. Someone said the best throw with the dice is to throw them away with medals. Gambling, the sure way of getting nothing for something. And Proverbs 1:19, so are the ways of everyone that is greedy of gain, which is taketh away the life of the owners thereof. Okay? So I wanted to share those with you. So, some key definitions. Let's understand what gambling is. It's risking something of value in the hopes of obtaining something of greater value. Substantial impairment may be related to gambling behaviors that may occur. Persistent and recurrent maladaptive gambling behavior that disrupts someone's family, their personal life, their occupational life, their vocational pursuits. So please understand that everyone who gambles does not have a gambling disorder. That's like everyone who drinks alcohol does not have an alcohol use disorder, okay? And I'll clarify all of that for you in a bit. You may have heard of the term chasing one's losses. That's when the person has an urgent need to keep gambling, and because they're placing these big bets, they end up losing so much money that they end up going after trying to win that money back. The chase is often frequent and long-term, particularly in gambling disorder. Let me say this, and I know Ms. Mellows and those of you that will work with me, Sister Smith, individuals who have a gambling disorder, they tend to lie. They lie to their family members, to their therapist, to the doctor, to conceal the extent of their involvement in gambling. All right? Deceit may include forgery, fraud, theft, or embezzlement to obtain money with which to gamble. During this year, while I was at the Community Council Assessment Center, the majority of people I saw who were sent to us by the courts were women. What? Women, yeah. And if I'm not mistaken, Shaniqua Smith, you can help me, I believe there were like 4 or 5
yes,
that were referred.
Yes.
All women, all right? Because of what they had done in terms of having to be taken to courts, especially by their significant others. I just want to throw that out there. So more research needs to be done to get a better understanding. I'm not hitting on women, I'm not hitting on you all. All right. Bailout behavior. Turning to family or other people to help you with your desperate financial situation. BPL is about to come and cut your light off. The bank is coming to repossess the car. You're about to lose your home. And so you turn to people to help what? Bail you out. Yes. Non-disordered gambling, professional and social gambling. Your people, like I said, who may gamble does not necessarily mean they have a mental illness in the form of gambling disorder. The risks are limited and discipline is central. For example, some Bahamians go to Florida and they play the lottery. They think nothing about it, right? And then there's social gambling. Typically occurs with friends and colleagues and lasts for a limited time with acceptable loss, and there may be problems associated with the gambling, such as short-term chasing behavior and loss of control. But the criteria for gambling disorder are not met. So, gambling behaviors, ladies and gentlemen, this is important. We now recognize it activates the reward systems in the brain similar to the way that substance use activates the reward systems of the brain. I'm going to try to break that down plainly for you in a little bit. And it produces some behavioral symptoms that appear comparable to those produced by substance use disorders. This is the reason why, and for those of you that are familiar with the Diagnostic and Statistical Manual, the 5th edition that came out in 2013, you would have noticed that they put together gambling disorder with substance use disorder, and it's for this reason. It activates pretty much the same reward system in the brain. So, comorbidities. Let's understand what comorbidity is. It's the simultaneous presence of two or more diseases or medical conditions in a patient. Okay? As an example, for those persons who have hypertension, and I knock on wood, but persons who have uncontrolled hypertension may end up having comorbid conditions of coronary artery disease, heart disease, along with kidney disease, as an illustration. That being said, particularly men, hello, please get your blood pressures checked. Walking around is called a silent killer for so many reasons. All right, you don't feel anything until, God forbid, it may be too late. But I digress. Drug. When we talk about a drug, Nurse Smith, it's any substance that changes the structure or functions of the body or mind. And I have that other than food, but understand food is a drug. Some of you got to have that coffee first thing in the morning at 8 o'clock, otherwise you don't have it. You moody, don't talk to you, you're irritable. What do you think that is? Addiction, right? You're addicted to coffee. Same thing with Coke soda. Alright, so food is a drug in the strictest sense of the definition. When we talk about a drug use, it's using a drug in a manner in which it is intended. It was properly prescribed to you. You didn't go to the African pharmacist. By the way, I want to shut that down because that's causing a lot of problems, right? Especially opioids. I'm surprised you've not dealt with that already, Brother Troy. But again, it's using the drug for which it was prescribed and for the person for whom it is prescribed. Yeah, I didn't mean to lash all of that out. I want y'all to start thinking about that. These things. Drug misuse. Now hear me today. Drug misuse is using a drug for the purpose for which it is not intended, right? Or using a drug that was not prescribed to you, or using a drug in the wrong dose. That's what I'm going to talk about, Sister Smith. Antibiotics. I prescribe 14 days of antibiotics for that's one person. They take it and they feel better by day 7, and then they give it to the other people the remaining antibiotics. What do you think is wrong with that? At least 3 reasons, right? Number 1, it wasn't prescribed to that person. Number 2, you did not complete the entire dose, and so therefore you are possibly going to contribute to antibiotic resistance for yourself. And number 3, for the other person. And possibly number 4, what if they have an allergic reaction to that antibiotic? Please stop giving antibiotics or medication that's not prescribed to other people. Okay? That's drug misuse. Drug abuse, the excessive and intentional misuse of a drug. All right, how are you doing, Sister Smith? Substance use disorder is loss of control over drug use, compulsive drug seeking, and drug taking despite horrendous adverse consequences, increased risk for relapse despite months or years of abstinence. Lots of drugs are out there, ladies and gentlemen. When I say out there in the public, right? Cocaine, marijuana, of course, both synthetic and the natural. Tobacco, black and mild, weed, this, that, the next. But I am concerned about this. Wow. My Royal Bahamas Defense Force colleagues, this scares me. My Bahamas Department of Correctional Services, this scares me. Something called fentanyl. Very dangerous. It's classically an opioid narcotic that is prescribed for people with severe pain. People who have those severe back pains from cancer, where the cancer is spread. It's 50 to 100 times more potent than heroin, oxycodone, or morphine. What makes it dangerous is a number of things. Number 1, you can't see it, you can't smell it, you can't taste it. Number 2, they're mixing it with other substances, putting it in brownies with the marijuana, putting it in drinks, alcoholic beverages, popping it as pills with other stuff. Why is this dangerous? Many reasons. But let me explain to you what happens when someone is intoxicated from fentanyl. It makes you feel good. You feel like you're flying high in the sky as if you could touch God. But once you start coming down, that person can experience any of these. The classic sign is the respiratory rate starts to go down. They get into some sort of a sleep and a slumber. With that, there is a horrendous snore, a high-pitched snore that person goes into. If you don't get that person to the hospital right away to get the antidote, which is naloxone, and my Royal Bahamas Defense Force, we need to get that on board, that person will die. Okay, preferably the one that's given intranasally. It works very quickly. If not, the one that's given by injection. What also makes it very dangerous, look at the dose. All it takes, Sister Smith, is one lethal-sized dose of a sesame seed. That's all it takes for that to kill someone. And we've had 2 Bahamians, based on the Royal Bahamas Police Force's briefing back in July, as well as several expats, and I don't know what the numbers are. But what makes that very interesting, Nurse Smith, is I believe that some of these people who may have died, we probably will not be sure if it was due to fentanyl being present out there. Okay, so it's out there, be aware of it. Literally, one pill can kill you. So, one definition I need you to understand is that addiction is a brain disease. I think by now, you should understand that. However, when I did my training with my colleagues for the gambling addiction certification, this definition blew me away. And it blew me away because I recognized that it was so common with our own people. It is defined according to the instructor who we were taught, Dr. Lynn John Van Beck. He said that it's a substitute satisfaction for an essential unmet need and a technique for avoiding painful emotions. I added temporary there because the person always goes back to use the substance. A substitute satisfaction for an essential unmet need. No daddy in your life, particularly in the context of girls. Not having any loving parents in your life. And a technique for avoiding painful emotions. Well, y'all know where I'm going with that, right? Incest, child abuse, molestation, being raped, all of that. And so people develop an addiction to deal with these unmet needs and to deal with this pain that is so being pervasive in their lives. Just as complicated as that looks, that's what addiction essentially is. All right, but it's very simple. I'm going to break it down to you. The cycle of addiction. I just gave you that definition, that new definition for some of you. So for people, some people would have had a lot of childhood trauma, childhood issues in their lives. As a result of that, they're wounded. When you're wounded, you have a certain belief system. That's essentially a negative belief system. I am bad, I'm not good enough, I'm a nothing, I'm a nobody. That leads to shame. When there's a trigger, and there are different triggers, you may be bored, you may be angry, you get into a relationship, the relationship ain't working out, etc., etc. That trigger then causes you to develop a preoccupation and an obsession and a fantasy. All right, meaning you use your imagination and think about what I could do to kind of hide behind all of this stuff, this messiness that's in my life. With that comes ritualization, meaning that the steps from trigger to acting out are the addict's rituals. And that might be every Thursday I'm going to go Awaki and get wasted. Or I may have a particular favorite shirt or clothes I'm going to wear to go to Island Lock, just to give an example. So those rituals then leads to what? Acting out, the behavior. And it becomes compulsive. That leads to despair. You start to feel a bit of a despair by what you've done. You've blown all your money away gambling. The kids now we have no monies for Christmas to eat or to buy them gifts. And so you end up having what? Shame and guilt. Shame and guilt. That can then propel you back to your wounds and the belief systems and the shame, and you repeat the cycle all over again. Or it could then lead to you having that preoccupation now. How am I going to deal with what I'm feeling? I feel bad. I need to do something. It's a vicious, nasty cycle. Okay, please don't judge people with addictions. Addiction, there is no cure. You can only treat it. And it's because of this, all of this, particularly in the context of that definition I just gave you. Are you with me, ladies and gentlemen? Yes. Why do people take or develop addictions or take drugs in the first place? Well, to feel good, right? We like feeling good. We enjoy pleasure. Feelings, sensations, and experiences that are novel. And to feel better, to lessen the anxiety and the depression and the worry and the frustration and the anger that I'm dealing with almost on a daily basis. But here's the interesting question. Why do some people develop addictions to alcohol and drugs and behaviors, and some people don't? Well, as with any other health condition, you gotta know your family history. Vulnerability to addiction varies from person to person. We're recognizing that there are not only environmental issues, but also genetics. Let me explain to you again. The signs of addiction, based on research, we're recognizing that certain people are more vulnerable to developing certain conditions, such purely based on their family history, their genetics. So what do I mean by that? Genetics may have come to up to 60% of why people develop addictions. So if you look at certain families, Sister Smith, you may recognize that quite a few of them seem depressed, like quite a few of them on alcohol or on drugs. And I know we say here in the Christian context they are dealing with generational curses. And yes, that may be true, you can look at it that way. However, recognize that it could be because of this, their genetics, which that person has no control over. Definitely there's environmental factors, as I've given examples already. There may be stressful life events that may occur. Hurricane Dorian, for those people who would have experienced tremendous, horrific situations during that awful hurricane. And then mental disorders such as depression or anxiety can also lead a person to developing an addiction. Are you all following?
Yes.
Beautiful. Let's look at the brain. Brain is an awesome organ when I think about it. How God created the brain. I hope everybody here believes that there is a creator in the form of God. But if not, I don't intend to offend you. But we recognize in research that certain areas of the brain are instrumental when it comes to that cycle of addiction. So as an example, as labeled in blue, colored in blue, the basal ganglia, which includes the nucleus accumbens and the dorsal striatum. The nucleus accumbens is responsible for the pleasure and rewarding aspect. So you just had lunch, no doubt if you enjoyed it, that was a part of the brain that would have been activated. Habits forming, the habits that we develop, is primarily recognized to be responsible by the dorsal striatum. Okay? The red, the extended amygdala, or the amygdala for short, involves the stressful feeling that people go through once they stop using a substance. All right, and so you feel bad, you feel irritated, you're moody. All of that is indicated for someone who's dealing with an addiction, that part of the brain. The prefrontal cortex, this right here, for God's sake, don't let nobody knock you here. That's the executive decision part of the brain. All right, you damage that, you're finished. When I say you're finished, you can't think for yourself. Can't do nothing for yourself. So the prefrontal cortex is involved with that part of the brain that makes the decision that I'm going to use the substance, I'm going to do whatever I have to do so that I feel good. All right, and with this, each of these areas, and it's simplified, it's a little bit more complicated, but it's simplified for you to understand. This addiction is a repeating cycle. Again, the basal ganglia involves the binge and intoxication stage of addiction. The extended amygdala has to do with the negative part of it, the withdrawal. Once a person stops using or stops doing that behavior. And then the preoccupation and anticipation, we recognize is the prefrontal cortex. That summarizes in a physiological manner what's happening, and even anatomically, what's happening with the addiction. And so, the cycle of addiction, very, very difficult, but we try our best to somehow break that cycle. And if you can break that cycle, you're able to help that person, provided that they want help, to be able to get the help that they need. Going back to high school biology, the basic structure of a neuron is implicated in the neurotransmitters and the electrical impulses that takes place in the brain to the muscles of the body and the organs. Neurotransmitter is the fundamental, the basic chemical that's used to help to transmit what? Messages in order to get a certain task done. And so we recognize that one key neurotransmitter is responsible for all of these and perhaps more. Movement, motivation, reward, and well-being, and even addiction. And that neurotransmitter is dopamine. You would have heard about dopamine. Very, very important, very vital in the context of addiction. And so the dopamine, as an example, is shielded in a synaptic, in a vesicle. And once that vesicle has several of those dopamine, they then go near to the synaptic cleft where it is released and where it binds to receptors on the opposite side so that therefore a particular task can get accomplished. I'm not going to go too much in depth with this, but I just want to show you the first two involving amphetamine, which we don't see much here in the Bahamas, but it could be here. Definitely cocaine, we're seeing, especially in Grand Bahama, Brother Troy. I don't know what's going on over there. All right, am I right, Ms. Meadows? It's true. I mean, we got to look at this from a public health perspective. But anyway, so in the case of each of these drugs, the orange represents dopamine, and the percent of it is released in terms of the time. So if a person is using this particular drug, you notice that compared to the other two neurotransmitters, that there's a dramatic increase in dopamine for both of those. So that's suggesting to me that this neurotransmitter is strongly involved in this addiction. And by the way, cocaine is one of the hardest substances to get a person off of. Yeah. It's a serious demon. Yeah. Am I right, Ms. Smith?
Definitely.
Wow. So drugs, ladies and gentlemen, are imposters of brain messages. So to give you an example, THC, and we're now at the forefront of considering, Brother Troy, we're going to legalize recreational marijuana. I don't know my views about that. However, for the point of illustration, so this is THC, the psychoactive component of marijuana, and the normal natural neurotransmitter anandamide that's responsible for memory, for pain control, for appetite. So what happens is that they're so similar in structure. A person who's smoking marijuana, the THC is going to bind to the receptor sites of anandamide, displacing it. And so therefore, when that person does not get that marijuana, if they've been smoking chronically, they're going to end up feeling a certain kind of way when they stop smoking it because of the fact of this disruption in the neurotransmitter system involving anandamide. All right, so drugs are imposters of brain messages. This is why with the developing brain, I don't have time to go into that, but for a brain of a child that is developing and the development does not end, we recognize till about maybe 23, 24, 25. And so what happens is once their brains are developing, they start smoking marijuana, they start drinking alcohol, God forbid using cocaine, it's going to mess up the entire neurotransmission system of the brain. The brains are not going to develop completely. They're going to have stunted brain growth. In other words, they're going to be dumber, if I can put it quite bluntly to you. Am I lying? Sister, you tell them something 2 minutes, they don't remember, you ask them to repeat it.
Right.
All right, and this is why we have to do something, because this is happening too often.
Yes.
12 and 11 smoking dope?
Yeah.
Are you kidding me? Drinking alcohol? You giving a child a sip of beer and laughing about it. You know what you're setting that child up for? All right, and we understand now, and so we got to get this message across from a public health standpoint. This is one theory that explains the whole system of the brain's involvement in addiction. Essentially, it says that all roads lead to dopamine, whether it's using alcohol or opioids or marijuana. And notice that for this particular theory, it recognizes certain other neurotransmitters, but they all lead to dopamine release. All right, so comorbidities, let's get into that. So what do we see? We see it all the time. Ms. Meadows, you can verify it. Ms. Smith, Sister Smith. Poor medical health, hypertension, their heart is racing, especially with gambling and substance use. Chest pains, some of them develop all kind of not only substance use addictions, but joint pain. I mean, we've had persons who have had heart failure using the drugs, and when they get to the hospital, to Sandals, detox, then they recognize that they have heart failure. And so now that puts us in a bit of a jam, because that's pretty serious. So substance use disorders in the context of gambling disorder comorbidities. Depression is definitely up there, and anxiety disorders. Certainly personality disorders, particularly borderline, narcissistic, to name a few. So based on research, one report noted that some of the most common comorbidities associated with gambling disorder include mood disorder, substance use, anxiety, ADHD. Believe it or not, quite a few of our adult population are dealing with ADHD. They can't focus, their office is cluttered, their house is in a mess. And it's frustrating. It's not that they don't want to do it, but they just don't know how to do it because of the whole mental aspect of ADHD. And then we label them as being rude, and we fail them, and we're beating them, and calling them dumb and no manners. All the time the child is suffering because of nothing that is done by them. Impulse control disorder, any personality disorder. All right, so the goals of management, whether it's gambling disorder, behavioral addiction, or substance use disorder, would include initiation of abstinence, sustain the abstinence, and prevention of the relapse. You have to know what stage that person is at. I have had families coming to me begging me, "Doc, please admit him into the drug program." And the man is saying, "I don't have a problem." You can't admit him, right? It's going to be pointless. If they're at the pre-contemplation stage, they're not ready for change. Contemplation, they're thinking about it, but they're not really sure. Preparation, "Doc, yeah, I'm ready. I'm tired of this. This is causing my life to be very miserable and messing my family's life." Actually, even better, where we've had, Ms. Meadows, some persons, they got to that point where they dump all the alcohol in the zinc and they come to CCAC and say, "Doc, I need to be admitted. I've had enough." Then there's maintenance, which we desire once they leave the program, they're able to sustain their recovery. And then, of course, unfortunately, because it's a brain disease, there's always that potential to relapse, especially when there's some stressful event that occurs in that person's life. And then some have fortunately been able to be terminated where they've been substance-free or not dealing with any disorder in terms of gambling for years. So, algorithm of stages of change, I do not intend to quit. If you hear somebody say that, you can't do nothing really much to help them except build their insight. I intend to quit, maybe in the next 6 months, contemplative. I intend to quit in the next 30 days, preparation. I quit less than 6 months ago, action. I quit more than 6 months ago, maintenance, give you some idea. Primary goal from the clinical standpoint, accurate diagnostic assessment, planning and initiation of effective intervention. And this has to be tailored to the person. There's no cookie cutter for everyone per se. Motivational enhancement is aimed at increasing someone's readiness for treatment and compliance with the recommendations that we give them as the clinical team. With motivational enhancement, motivation is needed to stimulate and more or less negotiate the accomplishment of recognition, recognizing I do have a problem, the decision making that I'm going to do something about it, commitment to getting whatever is necessary done, and planning the whatever needs to happen for them to get the help that they need. Two components of motivational enhancement include the style or the way of interacting with the patient. That's why I say to you, it's no cookie cutter approach. You have to develop a rapport with that person and for them to be able to trust you and to be honest with you. I never take what they tell me on the first day. I always take what they say to me on the very first time I'm meeting them with a grain of salt. Because there's almost always where they're minimalizing or they're not telling me the full truth. Number two, real talk. Techniques and strategies designed to increase engagement and accelerate movement through the process of change. And again, that's going to be based on the individual. So motivational enhancement and motivational interviewing. So motivational interviewing is broader compared to motivational enhancement, which is more person-focused. The benefit is to help for those of us in the clinical aspect to be able to identify, engage, support, and encourage persons who are dealing with these disorders and to help them with change. The best treatment approach, ladies and gentlemen, is the whole body. The whole body and the mind and even the spirit. The biopsychosocial spiritual approach. So in terms of the behavioral part of it, the psychological part of it, we need more psychologists as you educate them. Group and individual therapy. Cognitive behavioral therapy to help them understand the negative part of their thinking. Why are they thinking I have to have these substances? And it's so painful for them because they got to go back into their childhood where they were molested by their daddy or their uncle. And then there's, of course, the spiritual-based groups such as Alcoholics Anonymous, Gamblers Anonymous. Pharmacological, I think that's self-explanatory, not only the mental part of it, in terms of depression and anxiety and ADHD, but also medical issues that are going to pop up, especially once they get off of the substance or they get away from the behavioral addiction. And of course, family support, where Ms. Meadows and the social service team, where they fall through, and we are so thankful to have social service involvement. Treatment and management would also entail, if that person is having some withdrawal syndrome, my Bahamas Department of Correctional Services colleagues and Defense Force colleagues, this is particularly in the context of someone who is off of a drug. I need the Royal Bahamas Police Force to recognize that because people can go into withdrawals when they're not getting the alcohol, when they're not getting the cocaine. And of course, they're going to act erratic, all right? And as a result of acting erratic, then of course, that causes a bit of hysteria. But that person could be going through withdrawals. And so it is vital that you restrain them safely, get them to the hospital. Otherwise, they could die, especially with delirium tremens. Evaluation of the patient in the case of symptoms of imminent danger. Medical intensive management, meaning medical directed treatment in acute care, for example, Princess Margaret at Doctors Hospital, and then there's also PCA's level 4 facility and surveillance of the patient. Address any nutritional deficiencies. They are going to be deficient in thiamine, which is vital for the brain, in terms of other electrolytes in their body, sodium and potassium, that could be pretty much life-threatening. And you have to address the physical complaints and the comorbid psychiatric disorders. Hospitalization for the substance use and the gambling disorder definitely will entail if they are having acute symptoms that are life-threatening, and they have to be stabilized. Residential treatment unit would entail, for example, the detox program, teen challenge, BASH for those persons where there's no medical or imminent danger in terms of medical issues, and they require a restricted environment, especially with cocaine. It's futile for someone who has a cocaine disorder and say to me, Doc, I want to do the outpatient program. I can be honest with you, it ain't gonna work, okay, because of the strong addiction associated with it. But for the motivated people who say, Doc, I can't do the program, I gotta work, I gotta take care of my kids, all right, then we say to them, well, we'll design a program for you through the CCAC at the Community Counseling Assessment Center to help you to be able to get some form of therapy. So the goals of both gambling disorder, substance use disorder, is a multidisciplinary approach. It ain't only me, I can't do it all. It's definitely the nurses, the social service workers, the psychologists, the chaplain, occupational therapists, everybody is involved, all right? Further management, comprehensive education, family talk therapy must happen. Families do not understand. They say, I'm cutting bridges, I've had enough of him. But if they don't have that family support, they are likely to relapse. And I find once you educate them, bring the families in, help them understand what's going on, they're more receptive to being able to help that individual. Self-help support groups, and even these other conservative measures. I know some people hit on yoga, you're meditating and all of that, but believe you me, for some people that's beneficial. Remember, their lives are chaotic, just like that cycle of addiction diagram. And so all of this helps them to learn how to relax, how to use other techniques to help them to be more, develop a sense of inner calm and inner peace. Music therapy, one of my favorite. That's what I use all the time. Art, aromatherapy, acupuncture, massage therapy, diet, exercise, definitely high on the list. So on and so forth. And again, it's based on that person. What works for him, what works for her. So the referral process, ladies and gentlemen, listen, act, follow up, all right? And we recognize, of course, that there may be cases where you can't handle. So what you want to do is make sure that you know who you're going to refer to. In the case of the immediate situation, he's going through withdrawals. He's hearing the devil's voice in his head. He thinks that his mother is the devil, and of course he's going to try and kill her. Recognize it's the brain that's causing the issue, the brain disorder. Get EMS, and we need law enforcement to be available. And that's why we need the police to be aware of how to properly be able to recognize someone who is a mental patient and not pull the gun to shoot them. We don't shoot to kill, all right? If you need to injure them, try to restrain them safely. But don't shoot to kill. Family physician, general practitioner, the psychiatrist, the psychologist, the counselor, social services in terms of employment and home and food and clothing and shelter. They need help with all of that. If you don't have this, you're in trouble. And then, of course, the chaplain, definitely spirituality. So, as I end right now, ladies and gentlemen, we need more. I'm sorry. I'm done. In summary, addiction is a brain disease, right? And substance satisfaction. Persons with gambling disorder, substance disorder are susceptible to intense cravings. Comorbidities with gambling disorder, heart disorders, depression, anxiety, personality disorders. Motivational enhancement is a good tool to help move those persons along who may need motivation. The treatment should be a holistic approach, biopsychosocial spiritual approach. You may need to have referrals in order to accomplish that. More research needs to be done. At some point, we definitely will get to that. Yeah. These are some of my references. I wish to thank you on behalf of Emmanuel Medical Center, Dr. Noel Morgan, and myself. And I wish you all a very, very Merry Christmas and a wonderful New Year. I believe in 2024 is going to be awesome. Yeah. Any questions?
I'm trying to help.
Bring it down. It's an exciting stuff, though. Yes, ma'am.
Was predisposition only genetics?
Yeah, so genetic predisposition, so meaning, so the gene, your gene, whatever your family gene is. So for example, some families, like I mentioned, will have low serotonin levels compared to what would be considered normal in the average population. And so those families are more likely to be depressed. And as a result of being depressed, they use substances to deal with their issue. Or they sleep around, or they do these behavioral problems that can lead to vices. All right, so there are certain families I can just think of, about the mummy, the daughter, the cousin, all of them dealing with depression. And so what does that say? You know, we want to say it's a generational curse, but really and truly, it's a genetic predisposition that they have, just based on genetics. Make sense? Yeah.
I saw a word on the screen and I heard it before, but I don't quite understand what it is. Angina, I think.
Angina, that's chest pain. So with angina, normally when persons have chest pain, that's associated with the vasculature, the heart and the blood vessel. It's due primarily to a decrease in blood flow. And when that happens, then you have to take certain medication like nitroglycerin. That's going to open the vessel so the person gets that chest relief, so the blood can flow freely, more freely to the chest and the heart and the organs. All right, so it's a simple, fancy word for chest pain. All right. Like some people, it feels like a heart attack, but it's not necessarily a heart attack, but it could lead to it. Yes, ma'am.
Hi, John. You mentioned that there's certain steps, I guess, in recognizing that you have a problem. Let's say you have a person who does not acknowledge that they have a problem.
Yeah.
Everybody else can see it, but then how do you reach that person or get to them or
Yeah,
get
well,
them on some way because, you know, it's affecting the lot of it.
Yeah.
You can obviously see it, but
Yeah.
you're not recognizing.
be honest with you, the only thing I can think of is Meadows could probably help me or Smith is you build their insight. Try to show them very clearly why all of us are seeing as a problem. The family is seeing it as a problem, your best friend is seeing it as a problem, the doctor who just meeting you is seeing it as a problem. All right, so you try to build their insight to help them understand. And what I tend to do too is give them possible consequences that can happen, you know, because of their issues. I go very heavy on the possibility you could overdose and kill yourself and wake up dead. All right, so that's all right, that's what's
Just a little bit more in depth to what you were saying, like when you
Yes,
work
ma'am.
with us at CCAC, when they come and they are pre-contemplative, we usually would give them a return appointment the following week so that we could continue to give them some psychoeducation and motivate them. And that's been very helpful, I think, and getting people to the point where they realize, because now they're learning about so much of it and what it can do to you, and so it gets us to the point where they say, oh, I do have a problem. Now what are we going to do with it?
Now,
why did they come?
to add to Mrs. Meadows, if they're not at that state where they want to come back in the following week, what I would normally do, I'll just give them a green card and say, listen, whenever you get to the point and you recognize that you do have a problem, you're always welcome to come back.
Yeah,
Right.
doors open.
It's
Absolutely.
also very important for that person to understand, you know, that whole procedure, because if the family talks to the individual to coming into the treatment center, they don't stay. Okay, they exercise their right to sign up. We don't ever keep anybody against their rights.
We're not judgmental, because I think they look at us to say, well, once they come and they don't come, they're ready for us to fuss them. You're wasting my time, don't you? So once you come with them and you try it,
And then also you need key stakeholders that link between SRC and the community, and even CCAC and the community. Case in point, I have a client that I came into Nassau to visit at Sanders, and he is dual diagnosis bipolar, and he has substance use disorder. So it's important that you link with the medical practitioners, the psychiatrists that's providing the service in, so that as he or she transition out, you can continue that bridge from the inside to the outside. Okay?
Absolutely. All of the above. Excellent. That's all.
I'm gonna get a little personal, because this is my brother, and I I know he does go and drinks alcohol, he smokes weed, and like no longer than like yesterday, he works with my mom, and he'll go there, curse out, and my mom wouldn't. I mean, I wouldn't say she wouldn't do nothing, but I guess she's more afraid of what if she does something with the house. So I'm more concerned, honestly, say, how do you deal with somebody who's like literally completely out of control, but when you got the mother involved, she isn't gonna do certain things against her own child. So, what advice can you? And with all these wonderful smart people in here, give us some advice as I could try to leave here with some knowledge there.
Okay. Well, let me say this, and the rest of you feel free to chime in. I take security and safety very seriously. If that person, especially if he's a big guy, I mean, not even big, size doesn't even matter. They're aggressive, they're picking up knives, and they're coming at you, and you can't control them. I would say you need to call the police, and I'm going to get them to the hospital. I'll be real serious with that. Otherwise, someone's going to get hurt. Okay, potentially. So I would need your mom to understand that, all right? It's not that we're trying to do any harm to her baby, but we understand because of the brain disease itself, he's not in his right mind, all right? And you can't take that lightly. So I err on the side of caution, get them to the hospital. At least we can stabilize them. If they need to be admitted, they'll be admitted. They'll get the help that they need. They may be angry at you about it, but at the end of the day, they're safe and their loved ones are safe.
You're pretty much saying she needs to call the police to escort him to the hospital to deal with
the ambulance. So the ambulance along with the police, yes. I'm saying that in the case where he's extremely aggressive and violent and uncontrollable and she's fearful for her life.
So when he goes to the hospital, see what I'm looking at is, okay, when he doesn't go to the hospital, but like, is there gonna be something where they're gonna
Stabilize.
like keep him there or
Okay.
like what exactly?
Let me explain the process to you. The first thing what has to happen is to stabilize him. So stabilize him may mean giving him an injection in order to calm him down, to sedate him, all right? And they may possibly fall asleep. So once that happens, they wake up and we're getting the history at the same time, then we're doing the medical clearance. So we need to make sure that's not a medical issue. For example, someone with lack of oxygen in the brain, that will cause them to act aggressively. Or an elderly person with a urinary tract infection could act aggressively. So they have to be medically cleared. And that's why you have to go to the hospital, because we want to rule out any potential medical issues that we recognize can cause all of these issues. First time patients will get a CT scan of the brain. You want to make sure there's nothing going on in terms of a brain tumor or anything like that. So with the medical clearance, with the history, they'll be seen by the psychiatrist, the on-call psychiatrist, and if it's deemed necessary, then yes, they will be admitted. Or they may just need sleep. And getting that injection, I find, once they get a good night's rest, they come back to being more normal. Because a lot of these people, their lives are chaotic. They ain't sleeping, they ain't eating, they ain't doing anything to take care of their physical bodies.
It isn't that you said like earlier, I saw you mentioned something about when they're sleeping, they're like really those heavy snores and
The fentanyl.
When he sleeps, it sounds like he's near dead or like
Sounds like that?
it sounds crazy, and he falls asleep like he doesn't take long to fall asleep, but
Boy.
he's snoring so serious. I don't think he even get him good sleep.
But not only that, of course, I start to wonder is he using fentanyl? I mean, I don't know if we can confirm that. A lot of these stuff they're mixing could contain fentanyl. So depending on the high-pitched snort, I wish I bought a sample for you to hear it. It would make me wonder, is that happening? But more importantly though, you notice his respiratory rate is going down. I think that's the deciding factor. All right, our normal respiratory rate should be about 18 to 20 as adults. If you see them dipping down to 14 per minute, 12, 10, 8, then that's certainly a reason to be concerned. Wow. Now, how you know the person's respiratory rate, you can count when you inhale and exhale. You see the belly rising and falling. You can count within 60 seconds. And if that's dipping below 10, get them to the hospital. Don't take any chances.
Wow. Okay, if I can add also, there's two sides to that story. Your brother and your mother. Your mother may have very well developed what we call codependency because it's a son, that love that she has for him, right? She unknowingly to deal with all of that shame, all of that comes with touch with you, okay? She's now enabling his behavior. He is too close to her, it may take somebody else, okay, to call the police. Because she may actually just never do it because she feels that she's harming herself, okay, to call the police on her son to get the help that he needs, okay, because it's always two sides. And mom can very well become depleted, okay, trying to help her son. So self-care care is very important when it comes to mommy. Okay?
Mom's so weird because, like, when I say weird, it's like, I'll say, Mom, you want me, like, if I call my sister, like, you need to come and help, because, like, last night, she had, like, almost 2 kids. And my sister got furious, and I'm like, okay, if you come here, you can really, see, that's my blood brother, all my outside. So if I go, it wouldn't be so bad when everyone else come in, like, okay, you're all trying to gang up on me. So it's like, all right, I'll just go and I'll just see, make sure mom is okay. But it's like, okay, once another male there, he probably wouldn't be as aggressive. But then it's like, even like, even other day, he came there with somebody else with him. So it brought the intensity so high, and it's like, she knows this, you tell her what they're doing, it's like, so you're saying it has to be somebody else,
The
but
manipulation also, okay, the individual of the substance use disorder, it's a part of the manipulation to control the whole family. Okay, a lot of times that aggression and anger, it's really about manipulation and controlling everybody in the room.
So more about that when she do her presentation with, working at the family or family health.
Okay.
She's gonna elaborate.
thank you so much, appreciate it.
One quick point, do you think if you had an appointment with him at CCAC, you'll go, if you guys say you'll go with him, the family members?
I know he attempted to get help at one point, and then like after, like, I know earlier you was talking about they have to pretty much want to do it.
Yeah.
So at one point he wanted to get help,
Mhm.
but then it was like, he just changed his mind, he stopped going to the appointments, he
But
stopped.
if you can get him to go, the team can build his insight, help him to understand why he has a problem. All right, so it's a matter of educating them in the best way possible. So just as a suggestion. And then, so you should better, one of you can accompany him. That way, he feels he has the support.
Okay, let's give Dr. Knowles.